Okay, next we have Professor Tim Bickmore from Northeastern University, who's speaking on the age of compassionate computing. Please join me in welcoming Dr. Bickmore.
Thanks, Joe. So in many areas of healthcare, there's something known as a therapeutic alliance or working alliance. That's the trust that a patient has in working together with their provider to achieve some desired healthcare outcomes. And a lot of studies in many different areas have shown that this leads to not only greater patient satisfaction, but to greater adherence to what the provider is telling the patient to do, and because of that, better outcomes. So what do providers do to establish a therapeutic alliance? Well, they use a lot of the same behaviors that all professionals do to build rapport with their clients. Things like warm greetings, social chat, nonverbal behaviors like leaning in towards the client, smiling more, facial animation, and so on. But in healthcare, there's one additional behavior that's absolutely crucial, and that's compassion, demonstrating empathy and caring for the patient. So as we build automated systems that interact with our patients in contexts in which we can't have a human provider there, it makes sense that we want our patients to trust these systems and follow their recommendations. So maybe it makes sense to try and engender some feeling of therapeutic alliance between patients and our automated systems. But how could we ever get our computers to display compassion in a way that patients actually buy it? So let me take you on a little journey that I've had over the last few years in answering this question. So when I started my graduate work at MIT, I worked on a virtual real estate agent. And this agent would interview clients for their housing needs and show them properties that she had available. And we weren't doing this because we were interested in having more real estate agents in the world. I don't think that's ever been a problem. But I was interested in the role of social interaction in task contexts. So when I was studying for building the system, I followed a real estate agent around Boston and watched her interview new clients. And she in fact, she never said, "Hi, how are you? How much money do you have for a down payment?" She would start off her conversations talking to them about the family and about Boston and maybe a new job, and gradually transition into more sensitive topics. So basically building rapport to grease the skids for the task talk that was coming up. So I built a dialogue engine that emulated this behavior, that gradually transitioned from greetings into more sensitive topics. And when it came time for me to do my dissertation work, I was interested in finding some other area in which social interaction was known to have a significant impact on task outcomes. And that's when I found all of this literature on the therapeutic alliance. So this is the kind of system that I've been building for about the last decade now for doing automated health communication and health behavior change interventions. The system interacts with patients by simulating a one-on-one, face-to-face conversation with them. The agent talks to them using synthetic speech and a dialogue engine that dynamically assembles everything that it's saying based on discourse context, questions the patient might ask, information from their medical record, and so on. It uses simulated nonverbal behavior, including things like hand gestures, head nods, facial displays of comfort and caring and compassion. And when it's the patient's turn to say something, they touch what they want to say off of a touchscreen computer. So we use multiple choice touchscreens because it's important to me that we not just do demonstrations in the laboratory, but we actually build systems that we can put into clinical trial and out into the world. So we don't use speech recognition, for example. Okay. This is our virtual discharge nurse. This is one of the first systems we constructed in our lab at Northeastern. This spends about half an hour with patients at the point of hospital discharge, explaining to them their discharge medications, follow-up appointments, other self-care procedures. We've done trials now with about 500 patients that have been discharged this way. This is in collaboration with Boston Medical Center. Okay, so let me show you the first couple minutes of what this half-hour-long conversation looks like typically.
Good afternoon. My name is Elizabeth and I am here to help you with the discharge process here at Boston Medical Center. You're John, is that right? It is great to meet you, John. As you might have noticed, hospitals are very busy places. My job is to make sure that before you leave, you feel that you have been given all the information you need to help make the transition from here to your home as smooth as possible. So, are you a Red Sox fan? That is awesome. I would really like to see a game someday, but they don't allow computers at Fenway Park. Anyway. So, how are you doing today? That is too bad. Tell me more about how you are feeling. I am sorry to hear that. I bet that it is hard to feel sick, and it is not fun to be in the hospital. I hope you begin to feel better soon. I will now be going over some information with you. It looks like you are going to be leaving the hospital soon. I know you must be looking forward to leaving the hospital, but before you go, I want to review some information with you. This is a care plan that we created just for you. Remember to bring this booklet with you to all of your doctor's appointments. On the front, it has your name. And this is the day we are hoping you will leave the hospital.
Okay, so this goes on and on for quite some time. So the skeptics among you I know are asking, right, so a cartoon character talking to patients about their medical condition. Do they buy it? So we've done several pilot studies. We've done a clinical trial now with almost 500 patients who have interacted with this virtual discharge nurse. None of them have had any problems using the system. So we're doing this at Boston Medical Center, which is a safety net hospital. So we have a lot of patients who have never touched a computer before, never would, and have no problems with this simulated face-to-face interaction. One of the things we always ask patients when they get done with this half-hour-long conversation is, would you have rather heard this information from your doctor or nurse in the hospital? And what we've found across all of these studies is the vast majority of them say no. Believe it or not. So of course we ask them why. And the answers that we tend to get back have to do with feeling that they can take as much time as they want in a relaxed atmosphere to ask follow-up questions, ask for clarification. They don't feel talked down to, they don't feel rushed, and they really appreciate having something in the hospital room that's actually paying attention to them and talking to them about their health condition, and not being rushed. Okay, so patients can use it. They prefer getting their information this way, but does the simulated compassion really make a difference? So in one of our pilot studies, we randomized whether the virtual nurse just gave them the straight discharge information or also the humor and compassion and other behaviors as in the demonstration that I just showed you. And what we found was patients did notice it. They said that the virtual nurse, when she used these social behaviors, cared about them a lot more. But also, the information that she was providing to them was more useful, even though the information is exactly the same in the two conditions. So the addition of the social behaviors changed their attitude and evaluation of the information that was being provided to them. Okay, so patients can use it. They like getting information this way. Social behavior matters, but does this actually work? So in the clinical trial, we had 330 patients randomized to either get their discharge instructions through usual care or through an intervention that consisted of the half-hour conversation with the virtual discharge nurse, getting their discharge instructions printed out in a format for low literacy patients, a 3-day follow-up phone call from a pharmacologist, and some other elements of the intervention. We called them up 30 days post-discharge and found that those in the intervention arm were significantly more likely to know their primary diagnosis, that is why they were in the hospital. They were significantly more likely to have made it to their first primary care provider appointment. And for the 38% of patients who had inadequate health literacy, that is difficulty reading and following written medical instructions, we just about halved their hospital utilization rate. So this is ED visits plus hospital admissions. So this is approaching significance at 0.08. Okay, we've also been interested in following patients home from the hospital. So as you know, this issue of transition between providers is crucial, so we wanted to see if we could provide continuing care between the time of a hospital discharge and the first primary care provider appointment. So we built a web-based version of the virtual nurse that could continue reinforcing the discharge instructions to the patient, promote medication adherence, screen for adverse events and side effects, and also act as a mediated communication channel between the patient and their care team in the hospital. So if the patient had a problem, the nurse in the hospital would get an alert, she could deal with it, and then indicate to the system what action she took.
I am glad to see you. My name is Louise. We met in the hospital just before you went home.
Okay, so this is a very new system, and we've just started evaluations. Our most recent work in the inpatient environment has been building on this idea that patients seem to really appreciate having something in the hospital room that was paying attention to them and talking to them about their health condition. So we've been building a system that can accompany a patient throughout their entire hospital stay at their bedside. We call this our Hospital Buddy. This is, again, in collaboration with Boston Medical Center. We built a preliminary version of this last year that had 3 basic functions. It was a very simple standalone system. Patients could talk to the agent about their hospital experience. For example, it could commiserate with them about their hospital food. They could self-report pain and stress levels, and when the provider came in, they could show the provider their pain levels, for example, over time on a strip chart. And the agent could also tell them stories and anecdotes just as a way of keeping them company. We did a pilot study at the end of last year with 3 patients. We put it in their rooms for 24 hours each. Again, high levels of acceptance and use and satisfaction. They each had about 17 conversations with the agent on average over the 24-hour period using all of these 3 functions of the system. And when we interviewed them about their use or their experience, what we found is that the agent seemed to be effective at addressing their loneliness and isolation that you often feel in the hospital room if you're there by yourself. And we're currently expanding this work under a CIMIT Innovation Grant to expand the Hospital Buddy with a range of sensors so it can tell what's going on in the hospital room and use this in a number of new interventions. So imagine in the future it's 3 a.m., a patient's in the hospital room, nurse comes in to perform some procedure that could be delayed, and the agent pops up on the screen and says, you know, Mr. Jones hasn't slept in 2 days, he just fell asleep 20 minutes ago, maybe you could come back in a couple of hours. So it remains to be seen whether providers will actually heed those suggestions, but that's the kind of thing that we're interested in doing. Okay, we've also been interested in using these agents in preventive medicine in addition to the inpatient environment. One of the earliest projects we worked on here was in collaboration with the Partners Center for Connected Health. We built a virtual exercise coach that worked with sedentary overweight adults to get them to do more walking. And in this intervention, we provided participants with pedometers that they wore for 12 weeks. And we asked them to have a conversation on their home computers 3 times a week with our virtual coach for about 10 minutes. And we compared participants in this intervention to participants who also wore the pedometer but could just track their steps on a web page and manually set goals, which is representative of what many commercial products provide now. And what we found is over the 12 weeks of the study that participants who were interacting with the virtual coach did do significantly more walking as measured by step counts compared to the control group. Now, we've also been interested in looking at having these agents serve as a health communication channel for older adults and geriatrics patients, as well as patients with low health literacy. This is a project we did with funding from National Institute on Aging called Steps to Health. It was another walking promotion study. In this case, we gave participants pedometers for a year. We sent them home with a touchscreen tablet computer for 2 months. So these are geriatrics patients. They had a daily conversation with this virtual coach for about 10 minutes. At the end of the 2 months, they brought the tablet back. And then every time they came into the clinic for a regularly scheduled appointment, they could have a maintenance conversation with a kiosk in the waiting room. So I'm going to talk about some of the measures that we took at the end of the 2 months of daily conversation. And we stratified these participants by health literacy. This is 260 participants. And what we found is patients with low health literacy actually had significantly greater levels of satisfaction with the system. Possibly due to the narrative format of the interaction, the simulated face-to-face conversation. They prefer getting their information this way over, say, written instructions. So we saw high levels of satisfaction, ease of use, desire to continue using the system, liking of the character, and several other measures. And in this study, we also randomly turned on and off these compassionate social behaviors to see if it had an effect. And what we found was that for patients with low health literacy, it didn't matter. They had high levels of trust and therapeutic alliance regardless. But for patients with adequate health literacy, they actually needed this social behavior to get up to the same level of trust and therapeutic alliance as the low literacy patients. So it actually had an impact, but for a subset of the participants. We've done some design studies looking at different aspects of these agents that we could tweak to perhaps improve patients' reactions to them. One of them involved looking at how human we should make these characters. Okay, so should they pretend to have kids at home and a fight with a spouse last night and tell patients that they grew up in Tennessee, or would patients think that these agents were just being deceptive and not believe this? So we ran a study with one of our virtual exercise coaches, talking to older adults 10 minutes a day about their walking. And one subset of these participants heard the agent tell them stories about its childhood in first person, about where it grew up and what it did. For the other group of participants, the agent told them the same stories but in third person as if it were about somebody else, and to see if this had an impact. So based on self-report, patients said they were significantly more engaged and enjoyed the intervention when the agent used the first person. They didn't feel that it was being more deceitful. But most importantly, if we looked at their actual use, they were much more likely to log into the system when the agent was telling them first-person backstories. That is, the more human it was, the more engaged patients were with the intervention, and the more frequently they were coming back and logging in to talk to the coach. So this is important because, of course, getting people to use your system is sort of the first gate to getting any effective intervention done. And finally, I want to mention another design study that we did. This is the PhD work of Laura Vardilakis, who's one of the students in my lab. And she's interested in using different media for getting self-report information from patients remotely. In this study, we had another exercise agent that was talking to patients on a daily basis. At the end of the 10 minutes of coaching, the agent would ask them to estimate how many minutes of walking they did on the prior day. In a control group, the agent walked off and we asked participants the same question via a web form to see if that had any difference. So there were a lot of interesting results from this study. Basically, patients demonstrated more accountability when the agent was asking the question, and when we compared their self-report of minutes walked to pedometer steps, which is an objective measure, they reported significantly more accurate information when it was the agent that was asking them to report this information compared to just a web form. All right, so let me bring it back to this. This is the simple act of compassion and caring. And of course, we want a human provider to do this whenever we can. But as we build automated systems that interact with patients remotely in contexts where we can't have a human provider there, then it's essential that we design some aspects of compassion into our systems. Thank you.